Hey ReFam, my name's Kate and welcome back to Keeping It Real, the podcast that likes to learn from their mistakes. Today, Rich and Kim are running us through the most common mistakes that patients make and how to avoid them. They also tell us about the most important things they learned during their early doctor days and explain the difference between a complication and an actual surgical blunder. As always, if you enjoyed this episode, please leave us a 5-star review wherever you're listening or share it with somebody who you think would enjoy a peek into the mysterious world of plastic surgery.
So today we're talking surgery mistakes. I thought it had helped segment them into different genres of mistakes. What are some of the most common mistakes patients can make before they book surgery?
The most obvious one, and we're still seeing it now despite the amazing work of APRA, patients are still confused as to who is a qualified surgeon. So I had a patient even like a couple of weeks ago who'd had 2 weird consultations about what was a particularly complicated breast surgery, potential breast surgery, and had seen 2 quote-unquote surgeons who, as it turned out, were not surgeons at all. So they had not done any surgical training, and they both proposed bizarro operations well outside of their scope of practice and apparently didn't even examine her. Like, weird. So I think the biggest mistake is not going, it's twofold. One, not going to someone at least who is a surgeon. That is like entry-level basic research you need to do. The second thing is not going to someone who specialises in the area that you're intending to have surgery in. So don't go to a place so FRACS, okay, that's entry level. And most FRACS, which is a fellow of the Royal Australasian College of Surgeons, qualified surgeon on APRA as a specialist surgeon, particularly specialist plastic surgeon, most of them would be able to safely perform all of these surgeries, so tummy tuck, breast reductions, breast implants, breast lifts, body lifts, all those things. But then it comes down to what sort of result you're after. And so from that point of view, you then want to choose someone who is doing a lot of the work of the procedure that you're interested in. And you can work that out from social media. So are they posting? Do you like their results? Their website? Do they have a photo gallery? And then when you see them and specifically ask, how many tummy tucks do you do a week, a year, a month, whichever, and make sure that is an area. And they show you before and after photos that match your body type, that their results match the goals that you're trying to achieve. So I think the biggest mistake patients make is well before you're anywhere near a scalpel. It's choosing the right surgeon for the procedure you want to have done.
And a couple of other pitfalls that I have of patients, 2 things. One, there are a handful of people that are still coming to see us that know they're significantly overweight and not suitable for surgery. Not uncommonly get a comment. It's like, I know I'm not suitable for surgery, but I just want to see Kim or Richard anyway so that they can tell me what I have to do when they clearly know what they need to do. And if anyone's watched or listened to a lot of our podcasts, we go through at length the benefits of being at an appropriate body weight and the significant risks of being above that, and the fact that we're not going to be operating on someone. The surgery that we do is not weight loss surgery. It's body contouring after weight loss for a lot of it. And then the other one is smoking. It still astonishes me how many people come in and are still, social smoke a little bit or are vaping nicotine. So that's an absolute no for pre-surgery and post-surgery for us. Again, risks far outweigh any couple of puffs that you can be having.
Why do you think rushing into surgery, especially after childbirth or weight loss, can sometimes be a mistake?
There's certainly life events where you would not want to rush into surgery. I think the 2 examples you gave, they're relevant for a couple of reasons. One, in pregnancy, there's other things going on, so you need your babies to be a little bit self-caring prior to surgery. The weight loss one, look, I think as long as your weight is pretty stable and you know you're not going to put weight back on, they're both fine. The major life events, I think, where it's not a great idea to go into surgery would be more things where there's, for want of a better term, emotional baggage. So major events like a separation or divorce, they're very stressful times in your life. There's financial strain, there are other things going on. That's not a great time to be dealing with this, because recovery from surgery can be a bit of a emotional roller coaster. Major changes in your job, just starting a new job, also not a great time to be embarking on surgery like this, because there'll be a period of time where you'd have to take time off work, and if things don't go exactly to plan, that might be longer, and that might stress the relationship at work. I think you're trying to rush a surgery before a special event, like, we from time to time have this before a wedding or before a overseas trip, because it just adds another layer of pressure. Like, let's say you're planning to have a surgery like this prior to a wedding and things don't go to plan and you have to delay it. That's going to cause a lot of stress and put a lot of pressure on the recovery, and maybe put us in a position where we maybe need to do a revision earlier than what we would otherwise choose to do. So I think it'd be more the life events, the stressful life events, rather than physical changes. Those things we can deal with a bit easier. And if there's any external stresses and pressure, and everyone knows themselves, those things can make people make crazy decisions. You want everything in your life to be pretty stable when you're embarking on this sort of surgery.
It's obviously not exclusive to rushing in, but how common are surgeries that you guys do that are revision surgeries of surgery they've had elsewhere that they're not happy with?
Not uncommon. I guess a number of years ago, patients were heading overseas a lot more for surgery, and we would still be counselling strongly against that. That goes with what Richard just said about qualifications, and they may have a beautiful website and a beautiful looking facility, but you actually have no idea whatsoever what the regulations are in that country and what their training is. And if you've committed and already paid money and then rock up somewhere and it's not quite as advertised, you're committed to going in. I've got a patient coming up next week who went overseas for congenital breast surgeries or developmental breast surgery. She had tuberous breasts and got talked into on the day having implants and hated it from the second she woke up, and then had some other post-op complications that I've then been seeing her for over 6 months to let everything settle down before taking her implants out, and but also making sure that is the decision that she wants to go with. So cheap is very rarely cheap, and she's ending up paying significantly more money than what she would have.
Can you share a time you've said no to a patient who was maybe pushing for a very certain surgery that wasn't then?
It's not, I don't need to isolate a single time. It's not uncommon. I say no.
There are many examples, but I think a big one is we don't expect patients to know the answer or what operation is actually the most suitable thing for them. But I expect a patient to be able to articulate what their area of concern is and at least some of the goals that they're after. And we're very good at trying to elicit that information from you, whereas sometimes people come in and be like, I hate my breasts. And it's like, okay, well, are they too big? Are they too small? Are they too droopy? Are they too painful? Like, what bit is it? And us directing the questions like, do you like the size in a bra? That helps differentiate some of that as well. It's fine to not know the answer of how to get from where you are to where you want to be. That's our job. But if you can't articulate, if you can't actually say, like, I don't like my breasts because they're too small, I would like them bigger, I don't expect you to say, I want a 350cc teardrop implant under the muscle. But yeah, if you can't quite figure out if you want them bigger or lifted or smaller, then maybe think about that, or find some images on our website or our socials or online of things that your goals that you would like to get to.
There's a lot of talk about body dysmorphia. Body dysmorphia, I think, is quite rare. I don't think we actually see a lot of it. But one thing that concerns me more than body dysmorphia is what I call expectation dysmorphia. And it's along the lines of what Kim was just talking about. And it's where patients don't understand what we can offer and what kind of result they can expect. and they're unrealistic in what outcome they're going to get, either from where they are from a starting point, what their skin is like, what their breasts are like, pre-surgery. That, to me, can be a bigger concern than some of the other things that sort of people talk about more frequently. And it's along the lines of what we've been saying, for a patient to understand what the realistic goals of the surgery is. And there's lots of ways that we help do that. We use TouchMD. I draw on your photos to show where scars are. We show lots of before and afters. We've got simulation software for breast augmentation. But I think that's the real skill in plastic surgery practice and in having happy patients, is being able to match what you can achieve with the patient's expectations and explain it to them so that they understand and then hopefully exceed what you can do, but certainly don't under-exceed what patients are expecting.
Moving from patients to you guys, what do you think are the most valuable lessons you learned earlier in your career?
Having a collegiate relationship with someone, so if you have a complex patient, that we can discuss and share either the pre-surgery plan, thoughts, what we're thinking of doing, or if you've got a patient that has a post-operative complication, that you can also discuss management plans and things like that as well. So I think asking for help is always a hard but good lesson to learn too.
Have you ever had to adapt a surgery while it's happening to avoid a complication?
Probably without consciously thinking about it, like almost all the time. Like no, not significant changes to the plan, but surgery is dynamic and every patient is different, even though the number of surgeries that we perform are not great. Things like we inject local anaesthetic before we start surgery, and so that has to go in with a needle, patient's already asleep, but you're injecting local anaesthetic. And sometimes the very first time you put that needle in, it's like you just get a sense, and from that experience, that this patient is just going to be bleedy, as if, for example, like every time you stick that needle in, there's just like blood oozing out. So there's other medication that we can give the patient. It means that whilst we always take a lot of time, we take even more time, possibly put more drains in than what you otherwise would. Like in the back of my mind, I'm sure without really even consciously thinking about it, you always have the A plan, but then there's like a B, C and D, whilst the outcome's still going to be the same, but it's how to get there.
Yeah, so a lot of it is in the planning. So we would both spend a lot of time marking a patient up. So in many ways, that's where a lot of the decisions are made. But in virtually every single operation, you're finessing things. The more common thing with tummy tuck is I've marked how much skin I'm going to remove. I always test it prior to actually cut it, making the upper incision. And so I might back that off. Or I might say, actually, there's more loose skin here than what I was expecting, and I can cut out more skin than what I was anticipating. So every surgery is dynamic, and you can never just be in automation mode and just cut along the dotted lines and stitch it up and that's the end of it. I may look like I'm just in automation mode, but there's just always things that you're thinking of, and you're constantly looking at where you're at and making adjustments. Often micro adjustments, but adjustments nonetheless.
What's the difference between a surgical complication and a surgical mistake?
Well, I think a mistake is where you've actually done something wrong, and not for one of our surgeries, but for example, someone is booked to have their left kidney removed and they have the right kidney removed, or booked to have a knee replacement on the left side and they do the right hand side. So that's a significant mistake. If a patient's been given a medication that they're allergic to, when it's clearly documented, then that is a mistake. Whereas a complication is something that is an unexpected outcome, but it can happen, has risks, and that's part of our very clear consent process and our discussion with every patient every time, is that these are the potential risks, and pretty much everything we do, the risks are small, so would be less than 1%. Complications range from minor things like a minor wound infection where some oral antibiotics and the infection settles down really quickly, to something more major where a patient has a post-operative bleed, and that's not because a patient's made a mistake or we've made a mistake. It's because we don't complete the surgery and the patient's still bleeding, like everything stopped bleeding at the time. They go to the ward and then one of those blood vessels then starts bleeding afterwards. So that's a complication rather than a mistake. And the vast majority of complications are unpredictable, and if you have one, it's just damn bad luck, really. That's why we're experts as well, is that we can deal with all those things, and all the staff that we have around us, the anaesthetists, the hospitals that we work in, are all accredited to be able to identify an issue and deal with that. People can have things go wrong once they're home as well. So we have an amazing nurse on site. We've got great front of house staff who can direct inquiries in the right way.
Have you ever had a technically successful result that a patient wasn't happy with?
Oh, yeah. That comes back to what we were talking about before, which is matching expectations to the outcome. So it's not necessarily that we haven't achieved what we said we were going to achieve, but it's very different looking at a photo of a result to when you actually have the result or you've got the scar, comparing a photo to reality, and it's maybe not what a patient has expected, or there's some minor asymmetry after a breast surgery to objectively look at doesn't look significant, but for a patient they can notice a little bit of a difference in a bra or in clothing. And sometimes these things can be adjusted and improved. The enemy of good is better. So sometimes just trying to improve these things a little bit can cause another problem that you're maybe not expecting, and it's just not worth it. So you do need to be mindful of that. The other situation that can be difficult to deal with is where you've done the surgery, it's all gone well, patient is happy, get to the 6-week mark, everyone's happy, and then they come back at 3 months and they're upset about the result. And often what has happened is a family member or a friend has inadvertently made an offhanded comment, and then that's all the patient can focus on. And it can be minor things, either that scar shouldn't look like that, or either your breasts are asymmetric, or your scar is this, or your scar is that. And that can be very hard to walk back because patients, they're on the ledge and you've got to try and walk them back. And it's also confronting because last time you saw them, they were very happy, and we can both look at the photos and there's no difference from when they were happy to now. So I think you do need to take with a grain of salt offhanded comments that a non-surgical expert has maybe made in good faith and with good intentions. Sometimes maybe not. Maybe sometimes not. And really look at objectively if that actually is the problem. And don't dwell on these things and wait to your 3-month appointment. If someone has raised something, call us, come in. The worst thing we want is someone dwelling and stewing on something for 3 months. Then in your mind, patient's mind, it's become a much bigger deal. But I've certainly had patients who they've been in that situation, and then we can both objectively look at their photos and they go, oh yeah, you're right. Like that's not a big deal, or that looks exactly how it looked when I was very happy, and they're fine. But if it goes on for a period of time, it can become such a big issue mentally that it's hard to walk back from, particularly if you're always seeing that friend, they're always saying, oh, that doesn't look right, or whatever. So I think you do need to be careful who you show and whether you trust that person and whether they're actually being genuine in their criticism or they're just trying to mess with you a little bit.
To circle back to talking about doing those revision cases, I know you guys have talked often about how complicated that can be. Like it's harder to fix something someone else has done as opposed to just starting from scratch. Do you think they're more complicated physically or emotionally, like for the patient, or do they both play into it?
That absolutely both of those things play into it.
And financially.
Because a patient's already trust us implicitly. They already have that emotional attachment to, they've had an unsuccessful procedure prior. But yeah, like technically it's generally harder. And that's for those more complex revision. There are a number of very minor revisional things that we can do that are very, very successful, very easy to do.
What do you think are some things the industry as a whole could do to protect patients from mistakes, whether it's their own or from practitioners?
I think the big thing that's changed since the start of my career is collegiality. Kim and I are lucky that we've got a great relationship and we've been working together. Tried to work it out the other day, but I think it's maybe 12, 15 years, something like that. Yeah. And we've got other colleagues who we can also talk to about various procedures and patients. But I think broadly, plastic surgery as a specialty has become much more hostile and competitive than what it was when we were both starting. And, that this takes various forms, but it's very disappointing that the specialty, I don't think, it's never been more disrupted, separated, adverse, difficult in my entire career. And that's something I find really disappointing. We can circumnavigate it. I wish that we could go back to 20 years where people were a lot more supportive of their colleagues and it was more of a, for want of a better term, a safer place.
And finally, what's one myth you wish you could bust for patients in terms of surgical mistakes?
I think always assume that your surgeon has your best interests at heart. No surgeon is going out deliberately to harm patients. First and foremost, we're all doctors. We all got into medicine to look after patients. That's predominantly what we always want to do. That is always our intention. Everything we do is to try and get you the best result, the safest result, take care of you. And I think it can be very frustrating, disappointing when patients do lose that trust for various reasons. If your recovery isn't going as smoothly as you maybe anticipated, please don't lose trust in us or your surgeon if you've gone somewhere else. I think give them the benefit of the doubt that surgeons are doctors and they're trying to help you. They're trying to get you the best result you can and look after you. So that would be my biggest sort of myth buster, that for some reason a doctor or surgeon's not trying to do the best thing by their patients.
And a lot of that is communication from both ways. So if you've got a concern and if you're worried about something, we can't help you unless we know about it. So reaching out, coming in, getting looked at, as Rich was saying before about someone, if they've had that offhand comment and they're stressing about it for weeks, that could have not got so far or escalated so much if they just contacted, come in, have a chat. The door's always open. And then we'd much rather see people talk things through than not knowing what's going on.
If you liked that episode, there's plenty more where that came from. Maybe start with some of these or head to our channel for your peek into the mysterious world of plastic surgery.